why would we only collect a slice of information we need? And this is our big challenge in primary care, is we need a lot of information because people's lives are complex. Communities' lives are complex, and we don't have any simple questions, and we can't answer complicated questions with simple data. That's my thinking. I'll leave the panel members to react.
I'll comment quickly on this one. I agree with Andrew's response. I really kind of resonates. We do need a strong ethical framework to consider and go forward with something like a biobank. You know, like you just mentioned, we need a lot of data to answer these questions, and we need more sophisticated data. But the issue is the more drilling that we do into the EMR and the patient records, the more risk we have at unintentionally collecting identifiable information on patients and violating privacy. So I think that it's really important, to build trust with patients that their data is going to be used appropriately, build trust with physicians that the data is also going to be used appropriately. And then if you look to kind of make the biobank even larger and incorporate other data sets, so thinking of combining, you know, EMR records with health administrative data and things of that nature, we start to get even more barriers of kind of ongoing communications of very different kind of data sets and very different entities that are kind of organized and operating these data sets. So it's going to take a lot of coordination, a lot of trust, and I think that it really does begin with a very strong ethical framework, and I think patients, primary care have to be involved from the onset of this for it to go anywhere.
Yeah, I think again, as you'll see in the themes of our question, this notion is, if the owners of the data, who are the patients and not even patients, because a lot of people come into primary care before there's any disease or diagnosis. So if the owners of the data are your partners, then they'll know what you're planning to do with the data and how you're planning to do it. And you have the oversight right at the beginning, and you have a really strong ethical framework. And then that might answer your question about clinical trials, because in biobanks, you discuss what you're going to do, and you know, they will know in advance and say, well, yeah, I would like to participate when this comes up. And I've never ceased to be amazed at the generosity of community and patients in terms of their willingness to contribute time and effort, as you'll notice from today with Kylie being present, and their desire to see things move forward, to really see progress. That when you go into the healthcare system, you understand the gaps right away because you experience them personally. So they do want to see things improve for the better. Okay, thank you for that question. By the way, you can ask questions anonymously or with your name. It is completely up to you. So the next one that Andrew answered, but I want to read out loud because I actually think it's really interesting. I'm a little bit of a history geek when it comes to medical stuff. So I love the fact you mentioned John Snow. I've actually gone in London and seen the pump handle, but yes, I am that big of a geek. But so to build on the example of the Broad Street pump and applying it to present day, when the source of the cholera was identified, the contaminated pump handle, he just took off the handle, he left the pump there, was removed. How does this analogy work with things such as economically marginalized populations, anti-Black racism, or lack of affordable grocery stores, so what we call food deserts? What are we looking for today when we hotspot, and how will the complex interplay of layered inequities affect how effectively hotspotting can assist the healthcare system in responding to modern day equivalent of contaminated pumps? And we have a lot of those contaminated pumps, and we know they're there. So great question, whoever asked it. Andrew, you began to answer that. Do you want to go ahead and share your answer, and then we can see if anyone else has something to say to that.
Love to hear others' thoughts. Great question. I think, as I said, that in the case of anti-Black racism, this is the prevalence of racial discrimination. Where is it happening? whether it's by the healthcare system itself, which we know is unfortunately a place of anti-Black racism, whether it's in the justice system, education, and other systems. And that's why the layer map that I showed, the final layer is kind of, it goes from starting with the prevalence of diabetes, of type 2 diabetes, to the income, to the built environment, to then policy decisions. And I think this final layer should be maybe where we start to identify it, because instead of putting the focus on the individuals who have a condition as the hotspot, it's more what are the upstream determinants of that condition. Where did, like giving an example of food deserts, what is the root of that? How did that happen? How did that relate to policies made around transit routes? How did that come up to policies made around zoning laws? So I know it's a challenge for us, but we can do this, I think, and we can move to a system that routinely asks those questions. To take COVID as an example, instead of kind of the kind of focus on individuals who are getting COVID and where they are, one of the things is, how did that happen? Like trace it back to policy decisions made. One of our projects has been focusing on personal support workers who unfortunately have been deeply impacted by COVID infections, and in Ontario, a number have died from COVID. And how does this relate to the conditions of their work, the decisions made around privatization of long-term care and for-profit delivery of long-term care, the lack of access to personal protective equipment, as well as people having to work in multiple locations just to be able to make ends meet? So I think it's a great question, and I think it's kind of looking at the policies and what they are leading to, and in terms of the spread of infection.
Thank you, Andrew. I don't know if there's anyone else wants to comment. We will come back to this topic. It shows up a few times in questions in terms of patient-centric, and I think Kylie in her comments talked about this. You know, these are populations that aren't even making it into the system. So, you know, how do you ensure that our answers apply? If you're only doing research on people that successfully make it into the system, you're doing research on people that are being, as Kylie mentioned, are being cared for and are doing well. So, all right, let's come back to this. Thank you for that. So we have 12 open questions. I'm just going to start at the top. So it says, I assume this refers to you, Andrew. You use the phrase post-COVID. Oh, that was the title of our seminar series. What assumptions are you making about the primary care environment? Is this the magic of wanting to return to 2019? No offense, but I don't want to return to 2019 or 2020. I hope we can do better. Like, really, we should just skip right to 2021. Is COVID-19 eliminated? I think we know the answer to that, but I'll let you answer that, Andrew. And what about the economic recession, social change, new focus on changing current reliance and practice in residential care homes, etc.? So that's about 10 questions, but Andrew can read them here, and hopefully he'll have an answer for you. And I think that our panelists might also have some perspective on that. Okay, yeah. Go ahead.
I'd love to hear the other panelists' thoughts. Basically, I think as Jillian said, the kind of this series is entitled Post-COVID, but of course we all are aware that we're not yet in a post-COVID world, and probably never will be, because this is a new virus that now is part of our human world. And so what I think this meant, though, is as the first wave of this infectious disease kind of crashes over us and subsides, and we do see across Canada now governments moving to reopen, and including primary care reopening in a variety of ways. What does this mean? Where are we at now, you know, on June the 23rd, where we weren't back at late December? But also, are we going to continue trying to with what we did before, or are we somehow going to be changed by this? What's happened? How do we take the kind of this opportunity to make substantial changes? And I think I'll just note that I think these are what we're talking about are all really important things, but it's a conversation that isn't happening more broadly. So like this very important point that Kylie made of just basic access to care, it's not yet part of the public discourse. Like, and that's something all of us, all, 80 or so people who are part of this call, this is our challenge, I think, is to insert some of this thinking into the discussion right now, while there's an opportunity after this first part of this communicable disease outbreak.
Any of our panelists want to add to that?
I just quickly think wanted to point out that some of this, I think for me anyway, when I say post-COVID, part of the implication is what do we take that we've learned and try to leverage and maintain and build off of. I know there's a lot been said around the virtual care pieces across the country and in this province as well. So I think that, that I don't need to double down on the fact that, to a certain extent, the genie's out of the bottle on that one. But I do think that we need to sort of think about what are we seeing now? What can we keep? And we talk about this in our planning work too, to a certain extent, but what do we need to maintain and build upon? And what can we let go of? What were we doing that doesn't make sense now? And I know that, in the context of this conversation, we're talking research, but this is day to day too at a clinic level, I would suggest, in that a practice may see something they were doing before this and say, you know what, that doesn't make any sense anymore. And so one of the things I think from what we do and my team is how do you help support that change in a way that makes sense for the practice, so that if they're seeing things that just don't resonate anymore or don't need to keep happening and they want to go and do something different, that they're able to do that in a way that's controlled and measured, and that can have the best impact both for their practices but also for the patients that are ultimately the ones looking to benefit the most from this in that way. So for me, I think that's a big focus. I don't know why I always feel it that way, but when I hear post-COVID, I think the conversation a lot of the time goes to, well, where do we learn and where do we go and where do we grow?
Okay, there is a comment that I'm going to read because I'm not sure, that was earlier from Brittany Barber, and she's saying that I think it's an important point to consider is that primary care is inherently referred to as physician-centered care. However, there are numerous really important healthcare professionals that have a critical role in addressing population health needs and understanding patient health outcomes in the context of their community. Collaborative care centers should be the primary investment, and targeting the change from those single physician care models that do not have the capacity to address population health needs for patients, and the funding models to be inclusive of healthcare providers that have an equally important role addressing social determinants of health. Our understanding of primary care will need to change towards a more inclusive, patient-oriented model that meets the needs of patients across different community contexts. And I agree. What's interesting is I think in today's context where you're hearing all of these conversations about the policing and how they're funded and who's involved in the community contract, I hope that we'll see similar conversations about primary care, who's involved in primary care, and what needs to be delivered, and who is the best team member to do that. So thank you, Brittany, for that comment. If there's no further comments, we have quite a few questions. So I am going to move on to the next question. Okay, and the next question's it's a really good one. Okay, so the next question is, what lengths are researchers taking to ensure that patients understand that their socio-demographic data on the EMR will, 1, be viewed by third parties such as insurance companies, and 2, sold by the software companies that own these platforms? Ouch. So, and I know that Michelle Griever had made a comment earlier saying access to data cannot be restricted by vendors. We need rapid downloads and access. And that she's wondering if our network leads can advocate for this with relevant government and health authorities. Lack of data is really impeding the ability to follow the pandemic and to plan for primary care, as been well described by the panel. So this question, the other questions we've heard about biobanking, about notification, this is really, really, really important. It's about who owns the data, who has control of it, and who happens, and the notion of building trust. So I'm going to, actually, I'm going to let Matt, can you take Grandy, can you take a first crack at this, because you are a physician in a PBRN, And I think this is a really important point. This is a big trust issue. So I'll let you go ahead.
Yeah, no, I'm happy to take a stab at it. You know, I think this is a difficult, it's a very difficult question, and it's a great question. And in terms of, you know, having patients understand that their data is going to be viewed by third parties, such as insurance companies or sold to software companies. I mean, as a researcher, I think it's our job to ensure that that is not taking place. I mean, that's where the trust starts, is that the patient data is going to be used for the questions that we're trying to answer, and that it's being pulled from their charts, de-identified, anonymized, and utilized in, you know, a safe way. You know, the spin on that question is, you know, who does own the data and who has access to it once it's been entered into the chart. You know, the two main parties that participate in entering it would be the primary care provider, be it a physician, nurse practitioner, family practice nurse, pharmacist, anyone who's involved in a collaborative care team, and the patient, the person telling the story and giving the information. Once it's been entered, you know, you can see in Michelle's comment around access to get that data back out. That's where some of the frustration starts to rise, particularly from a research standpoint, because we can't snap our fingers and get the patient data back out easily. And that data is held by a third party, the third party being the EMR vendor that owns and operates the EMR that the physician is using. You know, these vendors are large entities for the most part. There are some small ones that still kind of exist in pockets around the country, but you know, with TELUS being a large shareholder for a variety of different EMR software systems, and QHR being another company that has interest in EMRs. The data lies with them, and the access lies with them often. There's often kind of a monetization model involved in trying to get that data back out. So from a researcher standpoint, I don't know if it quite answers the question around ensuring that the patients understand that the data will not be viewed by third parties like insurance companies and software companies. I would hope that from a legislation standpoint, I don't know if Matt Holland can answer to this at all, that there are privacy measures in place that the EMR vendors have to follow. But from a research standpoint, I think our own ethics and research ethics boards and whatnot would hopefully prevent us from breaching that trust with the patients and other providers that we work with.
Matt, any insight?
Yeah, I mean, without diving into the details of what's actually in the various systems, the various jurisdictions in the country, I mean, almost all of them, I think BC might be the only one, have personal health information legislation that does speak to this, not just from a research perspective, but also from who can access the information, when they can access, and when. I think what's also important to flag here too is what's considered identifiable versus not identifiable information, because your personal health record should not be shared with anyone outside of, I mean, even the staff with the vendor who access that for potentially providing tiered support on behalf of a physician or nurse practitioner or whomever who needs the help. They're supposed to be under very strict rules and guidelines and have audit trails around what they're doing so that that can be traced. But in terms of actually selling the information, if my own personal health information was ever actually disclosed in that way, that'd be a pure breach, plain and simple. But where it can get tricky, and this is, I can't speak specifically to certain circumstances, but vendors may be able to de-identify certain aspects or at an aggregate level. So, you know, maybe they can say, we know X% of our patients, you know, live here or live there. And so that is the sort of thing that I would highly recommend anyone who is going to actually start using a new system or put information into a system to read the privacy policies of their vendors to make sure that they're clear on that, because most primary healthcare providers, not all, because some are affiliated with the health authority, but most in the province are their own custodians of the data. So if you have a question, they should be able to find those answers for you. And so it's just really imperative that people know that when they're getting into these arrangements as much as possible.
Okay, so we have half an hour still scheduled for this webinar. We have 10 questions still to 11 actually, questions still to answer. So I'm gonna move on, but I know that not everybody will be able to stay for the remaining half hour. So I just wanna remind people our next session is July 14th. It is led by our Pan-Canadian Patient Advisory Council. So they will be speaking, they will be hosting that session, and it is entitled Making the Invisible Visible, and it's the power of patient and community partnered research in primary care. It should be a fascinating session. These slides will be available online soon-ish, as will the ones from the first seminar on our website. So if you Google Spore Picking, you will find our website. I'll ask Jamie to put the website in the chat actually, and everybody who participated in the webinar, we will be sending you a follow-up questionnaire so that you can let us know what you thought of the webinar and future topics you'd like to hear. Okay, so I'm going to go back to answering questions. They don't get any easier, but I think they're really great. So I hope the rest of you can stick around for the remainder of the session. Okay, Andrew, I like to pick on you, Andrew. Andrew, you mentioned the importance of community context and geographical methods to gain insight of patient health. What types of geospatial information are required from patients to enhance primary care? Easy question, right? I'll let you go ahead and answer it.
So in brief, because I know there's so many questions to go through. This actually was, I taught a course at our School of Public Health at a graduate level around the use of data, trying to build kind of data literacy for colleagues in healthcare. And one of the sessions we focused on was using basic off-the-shelf free geographic information or GIS system data to be able to start by just with the data we have, which is often the postal code of our patients. So we, because it's part of our OHIP or in other provinces, other health card information, often that's already available, and we can use that to understand where our patients live, just where do they live, how far do they have to travel to reach us, and what is going on in their communities. And it's fairly straightforward to be able to link that to other types of information that are available, whether it's on things like the degree of deprivation, whether it's the walkability of the area. So it takes some time, but these are actually tools that are available. And I like Matt Grandy's point about reach out to your practice-based research network for assistance with doing that type of thing. I think that's kind of the starting point. I think, of course, in the future, and this is to Kylie's point about patient-generated data, is I do think there's a flood of patient-generated data that is geolocated to a very precise level because it's collected through things like smartphones that is coming at us. And I think this is where, again, we need the governance process in place, because there is a tremendous amount of information that gets collected and that could be used, but are we ready for it? And have we set up the proper privacy and other procedures? So to prevent not only re-identification or release, but also a really important thing is stigmatization of communities. So one of the whole concerns that's been raised as some of this information gets released is it can stigmatize certain neighborhoods or communities. So what are we doing to, as a colleague here in Ontario put it, to make sure we're never telling the story without the people involved, nothing without us, nothing about us without us. And again, that's kind of the theme through a lot of these questions, I think.
Yeah, that's an excellent point. And I think one of our participants had made a comment that racism and inequity to him are symptoms. The causes need to be identified, like a belief in power over rather than belief with. and ingrained attitudes of privilege and entitlement. But I do think there are a lot of things like the built environment and safety. In Quebec, they did a fascinating project where they mapped obesity rates with locations where there were no access to fresh fruit and vegetables. So all the stores around you were convenience stores, and not, you know, there was restricted what they call food deserts. And the city of Quebec used that to place their farmers market. So instead of putting it in a very privileged neighborhood where, you know, there might have been a high demand for it, they actually picked a neighborhood where this wasn't easily accessible, and that's where they put their farmers market. So there's some interesting things can be done, but it has to be done in partnership and with trust. So thank you for that. I think one of the things going to be challenging is how do we put it all together in a coherent way and actually make this make sense? And I'm sure there's a lot of people who are hopefully putting some very sharp minds to that question about how we can do that. Okay, so we're going to slightly change topic, but we will be coming back to that data topic again. So this question is, many providers are expecting a backlog bubble when most of the restrictions have eased. Primary care data has been raised as a solution for triaging to get through this bubble. But are there any important elements we should be considering that EMR data doesn't or can't capture? And I think this again gets at access and equity. And somebody, I think in one of the questions we had a comment about social recession. You know, people who really desperately need to work and have lost their jobs or are going back to a challenging work environment may not be able to get to their primary care provider. So I think this is an excellent question. How can we use, what do we need, and how can we use that? So whoever wants to take that one.
I'll jump in really quickly, because I think this is what we're trying to answer with the aftermath study. And I very much agree that there are elements that we're not capturing. And this, again, part of what drives us to try to address that. There's one specific piece is actually information on occupation. So we don't traditionally in Canada have this data in any kind of standard way. And we've learned during COVID how incredibly important whether or not someone has a job or not, and have they lost their job, but also what sort of work they do has been interesting. In Ontario in public health, they just asked people, are you a healthcare worker? But they didn't delve into what sort of healthcare worker. And of course, the difference in terms of COVID rates and deaths is tremendous between a physician or nurse or a PSW. So that's one example. We've actually did some research on asking patients about their occupation and using a simple tool to help categorize occupations. It turns out it worked pretty well, just someone putting in basically their current job, and it helped to identify what it was using an international labor classification system.
I can kind of build on that a little bit too, maybe less so from the triage piece, because I mean, I'm obviously I'm not a clinician, as I said, but one of the big considerations that we have right now, I think, is trying to figure out just what is possible in terms of seeing people. And one of the things with, I think, and I know that I've heard, I was part of another webinar where they didn't like the term restart, but if we do see an opening up and an increase in demand in services, how are we tracking that demand? And it's going to be very difficult to dive into the EMR and look at past experiences in the EMR when this is brand new. So some of the work that we've done for other projects is we have measurement sheets that you capture the daily demand. So how many people are calling for an appointment that day? How many people are you having come back for an appointment that day? And then mapping that against what you're saying is your supply on a daily basis. So it's very prospective, definitely not something you're going to get from the EMR, but what it could potentially help with is give you more real-time data to say, oh, wow, like last week we had, 50 calls on a Monday to come in to see 3 providers, and this week we saw 70. What does that mean? And then also get a sense of how many of these people, and then you can, potentially slice and dice that a little bit to see, are they people coming in for follow-up? Is it chronic disease management? Like creating some of those, it's kind of crude, it's on paper potentially, but it gives you information that you can use right then. that is related to our scenario today versus looking back at a year of EMR data that may not matter at this point in time.
And of course, that's not going to help us at all with the people that don't have access to the system currently, or who might have lost access to the system throughout this process. So lots of fun challenges. Okay, I'm speeding up a tiny bit. We have another question here. And this is one of the attendants said, so as we have understood what matters to patients that encourage them to provide data, do we know what matters to the government or ministries of health that will encourage them to support the collection and use of this data? So I think, Matt, that might be yours, although maybe Kylie has some perspective in her role in the network as well. So do we know what it matters? What matters to you to support the collection of data, Matt Holland? Putting you on the spot.
Putting me on the spot. See, who knew I'd have to come in wearing 2 hats today? I think, you know, the main thing with this is, I mean, I hate to kind of come back to the whole notion of involvement and people being aware what the information is being used for and what the purpose of all this is about, but that's sort of where it stems. And, you know, the matter of having a coordinated effort around this is really huge as well. So I don't think that can be dismissed, but I think everyone puts value on it. I think it's the coordination that's necessary for all of this and making sure that everyone's pulled into it to make it happen. And I can speak from past experience that there is a lot of effort made to make that happen, but at the same time, there's just, I mean, and I hate to use the word interest because it gives a sort of a self-interest perspective, but also a lot of times, and you know, maybe I'll get my hand slapped historically for this, privacy is used as an excuse and it's not really the issue. My experience has sort of demonstrated to me that if you really want something to happen and you can demonstrate the benefit to the patient, whether it be through research, whether it be through quality improvement, whether it be through other, you know, sharing within the circle of care for whatever purpose, that the legislation is actually fairly forgiving, but it needs to be tied to that. And sometimes I think the burdens to get to that in terms of steps and process get in the way of what the legislation actually is allows you to do. You can go right into our legislation and read about it, and up front it tells you that the reason why we have unique legislation is to allow certain activities like this to actually happen. And that in the healthcare setting, things are a bit different. So once you kind of get that front of mind, then the rest of it should come from there. And I hope I didn't skirt that too much, but I just think it kind of just dials down to the fact that a lot of this is it's the art of the possible, and making sure you can get the right people involved.
One of the things we're trying to do in the network is understand the difference in timeline and certainty of answers that are so very different in the research world versus the policy world. Like as researchers, you'll never hear us use the word causation, and we get really nervous about making strong statements, and the policymakers like, I need 30 seconds. You got 30 seconds to tell me before I go into this meeting. So it's an interesting, I think that is a question that actually the way our network is set up is meant to help address, because we have a policy lead involved in every network across Canada. Andrew, is there anything you want to add to that before I move to the next?
I guess, yeah, just to add that point, that I think we've been fortunate to have policy makers involved with different projects, including this one supported by the SPORE call. And but as Matt said, it's a work in progress. It's like an iterative discussion of sharing with policymakers. Here's what we're seeing. Here's what patient partners are saying is important to them, and then hearing from them what's often important for them often relates to financial issues. So is your intervention going to reduce healthcare costs, yes or no? And trying to expand that, you know, and it's an ongoing discussion, and sometimes I think policymakers, the thing that speaks most is the impact on individuals, and bringing that real story of what this has led to often makes a big difference.
Okay, thank you. Kylie, the next question references you. Your comments about the Dal report reminded me of a conversation on Twitter around how some communities of color feel that the data has been used to target them in unfair and oppressive ways. If we rely heavily on data to support post-COVID work, to what extent do we run the risk of doing the same? So I think we've already heard about the risk of these communities being completely absent in the data, but how do we avoid the punitive aspect if, you know, there is a higher risk or there's an issue for different communities? So I think,
well,
Andrew, you had referenced it early, but go ahead, Kylie.
No, it's definitely not a question that historically we have used that data against these certain communities. I think we still do, you know, they're like Andrew was mentioning, like communities are stigmatized, you know, where they live. I'm definitely probably not, you know, the best person to speak about that. In Nova Scotia, we have amazing researchers, Dr. Ingrid Waldron, Dr. Barbara Hamilton Hinch, who are, you know, working on, I guess, these issues, or would have probably something better to say than myself about, you know, how we should be approaching these situations. From my opinion, is, and what everyone's kind of saying on this call, is that we need to be working with communities, and not just researchers, not just policymakers, but there are amazing community activists and advocates. We see it in, you know, with the opioid crisis and the people working in harm reduction, about what they've been doing with researchers and community activists and their work. And I think we have just a lot of work to do with the community, and that's, I mean, I think, like I said, there's scholars, you know, and researchers and community activists who would have more concrete, maybe, you know, steps about how to approach it. But yeah, I think we know it can harm people, and it scares me about how we use data.
One of the things I'm optimistic about is in Canada, with the founding work with Anne Macaulay and her partnership with the Mohawk Nation in Montreal, some fantastic work with the Indigenous group at CIHR and a lot of different players. They came up with guidelines that you have to, if you're doing research with Indigenous communities, and that is a group that historically has been incredibly stigmatized and penalized by non-Indigenous research. And if you are going to do any research or healthcare research with Indigenous groups, you have to do it with them, and you don't get to publish or analyze anything. They own the data. They say what gets done and how it gets done. And I think maybe we need to more systematically, as Andrew has said and many people have said on this panel, we need to more systematically do that for all groups, all racialized minorities and different groups that could potentially be at a disadvantage. And then that earlier question we had about, you know, not letting the insurance companies and EMR vendor, that all of that would be sort of encompassed in that approach, that you don't collect any data without the people you're collecting it on working with you and determining how it would be used. So I think we do have some approaches that would, and I think this is something we need to be very, very, very aware of and cautious of. So thank you, Kylie, for saying that.
To do that as well. I mean, I'll just like kind of go back to Matt's point, but as a patient partner and a patient, it makes me deeply sad that a pandemic took, you know, like now we have virtual care. People have been fighting for virtual care for years, and now all of a sudden, and I know that's a narrative that's been going on, but, or that what's happening, you know, against what has been happening against the entire history against Black people, Indigenous people, and people of color, that all of a sudden, you know, now we're taking action. Like we truly, as like researchers, patient partners, and people with privilege, have a responsibility. And it's just not a question anymore for me. It's like, we need to be doing things. And after this call, we need to all be thinking about what we can do. We saw that virtual care is possible. Maybe it is giving more access to people, maybe it's not, but things are possible. And I think it's, I'm just like very over the excuses, I think. And I think a lot of people are frustrated from that. But as a patient partner, I think I have like a duty to, you know, say that.
Absolutely. Sorry, Andrew, if you could make this, because we still have 8 questions to get to, and we have less than 15 minutes. Go ahead.
Really brief.
You want to say anything?
Just thank you, Kylie, for saying that. And it's, I think I'm saddened also that it took a crisis to uncover these issues, which, as you said, many people have been saying for a long time, including our colleagues in Indigenous health research around following OCAP principles. But what I'm even more saddened by is I see that things could return to the state that they were if we don't raise our voices, and also just have a collective plan. And again, this network is so powerful because I think it has the potential to actually have us focus on a set of recommendations going forward that then we hold government to account.
Mm-hmm. Thank you. So the next question, we spend lots of time talking about patient-family-centered care, and for some reason we've missed the boat on non-COVID patient admissions with the family inclusivity. A critical part of patient admission is the individual's mental health and stability, and the family member is that safe haven for that patient. Right now we ignore that the safe haven for patient, as it seems like PIHCI is a wish, that's patient-family-centered care is a wish list. The issue will fall back to primary care. So what are we doing moving forward to protect the patient mental stability during admission and hospital stay? So actually, there's something there that they're expecting a second wave of COVID infections, but there's something called the third and fourth wave. One of those waves deals with mental health issues, and one of those waves deal with non-COVID health issues. So Andrew, I know that there's no, or maybe Matt Grandy might want to speak to this. I know there's no fast answer to this, but I will ask you to try and make a fast one. Matt Grandy, do you want to try, and what do you think about this family-centered? And there is a question we're going to see later on about informal caregivers and whether we're capturing that information. So obviously this notion of family members and family-centric care. Any thoughts on?
Yeah, I mean, I guess one of my comments would be around, I think we're already seeing, you know, patients who suffer or are affected, you know, with mental health stability issues have already been significantly affected by COVID. You know, we're seeing that in terms of the way they're engaging with the healthcare system and primary care currently. I don't know a lot about, you know, how in Nova Scotia we're implementing patient family-centered care. I think the issue is already kind of falling to primary care. So I don't know how much of it will fall back to us if it's something that is already at the forefront of how we're managing these folks. You know, I'm hoping that, you know, as a result of how we've transitioned into the post-COVID world and how we, you know, are going to gain a better understanding of what patients are engaging in the system during this time, who the vulnerable patients are. I do hope that that helps us for the next waves to come and helps us better triage, manage, and identify vulnerable folks. So the issue doesn't have to primarily fall kind of into primary care or become you know, an urgency. It's something that we know at the outset that these people will need an increased amount of care, a focus on family, and can push them in that direction right away. I would hope, you know, speaking to Andrew's point in his slide, moving to, you know, a proactive kind of response as opposed to a reactive response to things.
Thank you for that, Matt. I think this reflected back on our earlier question about not just family physicians being part of the team. There's a lot of primary care healthcare providers, and mental health implicates a lot of them, like social workers and psychologists and different people that can be involved and need to be better integrated into those teams. So again, coming back to this notion of, can we do things better going forward? And can we use this crisis? Yes, Kylie, I agree with you. It shouldn't have taken this, but let's use this to, you know, spring forward on a lot of these changes that have been needed for a very, very long time. Okay, our next question. Can we use existing community organizations, health-related organizations, to promote education on health literacy for citizens to be involved, educate on what's important to the health system to learn, so we as patients can be more effectively served? So the short answer to that is yes. I don't know if anybody wants to. And that is something that our network is really, really, really interested in. And actually, Denise, I would encourage you to attend the July 14th session, where you're going to hear from our patient partners on exactly how they've done this. And one of the reasons why we call it patient and community partners is because the community is so key in this. So Kylie, I don't know if you want to add to that. briefly, but I think there's clear demonstration of that being possible, right?
Yeah.
Yeah, so see there, Kylie has the same answer as me. Yeah, absolutely, definitely.
I mean, we can always
And
do
people should be
better,
involved.
but
Yes, we can, but there are a lot of existing organizations which unfortunately were completely shut down during COVID. And it's a matter of like, how can we help them get back on their feet, that had strong links into the community, and that really is the way forward to getting at some of these marginalized and disenfranchised populations. So thank you for that question. Expanded answer on July 14th. Gail, you have asked a very long question, but the next ones will have a lot to do with data collection, so hopefully we can answer them sort of all. But PREMs, PREMs are patient-reported experience measures. I worry that we overlook the nuanced difference from that and patient-reported outcome measures that reflect an individual health needs, whereas patient-reported experience measures reflect their care and shines a light on the providers. How will patients feel about providing information about their experience of care if the information goes directly back to their clinicians? So will there be a reluctance to report wait times, perception of negative provider or staff behavior, etc.? So Gail is basically asking, how can we design a system of collecting this information to ensure patient confidentiality? So it's very similar to questions that have already been asked, and I think it's an important one. So Andrew, do you have an insight there?
Yeah, I'll just note that this is actually something that has been discussed and kind of explored in Ontario for a little while, in part driven by the emergence of new forms of care like Ontario health teams, which are these integrated care models. And there's an idea of like, how do we really judge people's experience across these types of models and also outcomes and compare across teams. And it also builds on some amazing work being done by colleagues led by Tara Kieran here at U of T on patient experience of primary care and trying to come up with a standard approach to it. So we actually received just a few weeks ago a small grant from the Ontario SPORE Support Unit to do a project looking at patient-reported outcome measures and patient-reported experience measures and patient-reported or inferred social measures. And so we're hoping to do essentially a pilot, which begins with asking patients, Gail, what you noted, which is how do patients feel about this? What works for them? How do they feel about the information being collected, aggregated, and provided back to an organization? What can we learn from previous experience, and how do we commit to also using the information? Because again, there's a lot of data collection that happens and then not action or accountability. So that like, what could it look like if primary care organizations actually had to report publicly on these measures, whether it's like people's ability to access care or outcomes? What would that look like to provide it in aggregate to providers? And so there's a lot of great work from within quality improvement that we can build on, but I'm excited to see that happen, and also see how the data should be collected. So how do we make sure, if we're using like email surveys to people, how are we going to ensure it's actually reaching people who don't have access to the internet or who don't have access to a phone or are living in a shelter, like many of my patients? So how can we make sure it's also built with that lens?
Okay, so we actually, sorry, go ahead, Kylie.
Also the lens of like, are these culturally relevant? Are they trauma informed? Are they are your providers culturally informed, race informed, trauma informed care? If people aren't going to want to answer these questions, if they are not coming, if they're not relevant to them, if they are also not appropriate, and if you do not feel like your healthcare provider understands and will use them appropriately, and it goes back to that trust aspect.
Okay, we are in the last 4 minutes of the seminar. First of all, I'd like to thank Jamie DeMore and Steph Hindle for all their help organizing this in Brick, Nova Scotia. We have 5 questions left. They're all about data and data access. So are physicians being used to recruited to collect this data? What sort of primary care data is needed to support patient care in the future, what's getting in the way of that, all the new telehealth and virtual health. How is this rapid shift in the kind of care going to affect the questions we ask of the data? That's a very important one. Are we capturing data done by informal caregivers, which has probably increased? And there's another one saying about meaningful EMR data use around and team-based care. What sort of system level support these clinics need in getting at the gap. So what I'm going to ask is that each of you take 30 seconds to wind up and any last thoughts you have on data. So Andrew, we'll start with you, and I would like to in advance thank all of you for taking the time. It's been a fantastic session, and I apologize to the last 5 people who are going to have a very, very fast answer to their question, but tune in for the next series for this. So Andrew, go ahead.
I'll just answer brief. First, thank you again for the invitation to speak, and look forward to continuing the discussion because there's so many things to still explore. I'll just mention that to the first question, that this data I don't think would be directly the physician responsible for collecting it. It would be more that it's data that we've done in our family health team since 2013 is actually offering it to people on a tablet as they're in the waiting room, and making sure that people are very clear that this is all voluntary. They don't have to answer this. It's not going to impact their care, and that it's being used and becomes part of their health record and kept securely. So lots of things. I'll maybe just end on saying that this. I'd really love to work with others on building this vision of the primary care system we all know needs to be created, and would welcome the chance to kind of collectively maybe work on a joint set of recommendations that we would then bring to provincial governments to say this is what we need to see happen.
Thank you, Andrew. Matt Grandy.
Okay, yeah. So, just responding to Andrew, I would love to be involved in that work as well. I mean, I think it's so important as we move forward. In regards to physicians or primary care providers being recruited, I would say from a practice-based research network standpoint, the answer is yes. So we're continually recruiting for our practice-based research networks. So if that is something for any of the Nova Scotian providers on the call, if they're interested, certainly contact me. I'm happy to talk more about it and give materials around that. And then quickly, kind of from a data standpoint, I think as the healthcare system has responded and reacted to COVID, those data are certainly going to be reflected in, the EMR. The big question is, how do we get that data out, and how do we get it out in a meaningful way, and how do we ask the right questions of it? So it's really bringing the right people to the table. And I think throughout the conversation today, we've heard from everyone that the right people have to be there from day one. We really, as researchers, need to listen before we act, and we have to continue to build that trust as we move forward.
Great. I'm going to skip to Kylie. I was going to let her wrap up the last word, but she actually has a meeting right now, as do I. But Kylie, any last words? You will have your time again in July 14th, but any last words for us about this?
I'll just say thank you so much for letting me speak, and thanks to all the patient partners on the call who always inspire me to do better, and hoping just people can take something away from this and learn from it.
Thank you, Kylie. Matt Holland.
Just to echo what Matt Grandy said about being able to use the information, but I think we need to be thinking this too in terms of program development and operations, and thinking about how we move in a direction where everyone can access that. The one question that was left on the screen for me was what is the roadblock or the challenge to this? And I think I used the word coordination before, and I'll throw it out there again. I think we just need to work together and figure out ways for this to happen, because this information and being able to use this data is only going to be valuable if it's at the clinic level and they're able to make decisions based on that. And as a systems person, we can only work from that at the same time. So
Thank you, everyone. A fantastic session. I learned a lot. It was a great pleasure. Thank you to all of our incredibly patient participants. Great questions, and sorry for the rush at the end. Have a wonderful day, everybody, and I hope to see you on the July 14th call. Thank you to all my panelists and Andrew, our speaker.
Bye,
Thanks,
everyone.
everybody.
All right, thanks, folks.